Hey, Section 4. I hope this Block 2 wrap up finds everyone doing well. I apologize for the brevity of this as I'm in a hotel room in St. Louis right now, getting ready to take off with my family. So I'm trying to juggle a lot of things at one time. So, as a quick review, we're going to just kind of go in. I just want to lay some comments down. There was a lot of good discussion about shoulder disorders this week, whether it was impingement syndrome, whether it was adhesive capsulitis, whether it was a shoulder instability. A lot of you, got some good information and were able to take it and synthesize it back into clinical practice, which is always really good and something that we're looking for. So, first, some of my comments. The McClure and Michener article was really good for a lot of people. We're looking at a better way to classify shoulders as we talked throughout the week or over the last 2 weeks with Block 2. There is this huge debate about whether how we should be diagnosing these, and that shoulder impingement is this broad umbrella of diagnostics term, and it covers everything from rotator cuff tendinopathy to mechanical blocking to and then everything in between, even partial rotator cuff tears. So we talked a lot about pathoanatomical and the movement-based system and irritability. And everybody kind of agreed that the McClure and Michener article was a good first step. I don't think it's where we're ultimately going to land, but I think it is a really good first step. I think it's a guiding article moving us forward, and it'd be one of those articles, one of those seminal articles where you're going to look back on and be like, okay, well, this is what's kind of guiding us to where we currently are 5 years, 10 years down the road. I was speaking. I told a couple people that I was speaking with Paula Ludwig of the University of Minnesota. We had a faculty dinner last week, and I was asking her about this particular article, and she's got a lot of really. For some of you, I posted some articles that she has done. She's got a lot of really good research. She's right there with these guys in regards to trying to figure out. She believes more in the movement-based categorization, although I would argue that, gosh, even movement-based stuff, if you look at what Sauerman's done, I mean, there's some good stuff there, but it really hasn't held up yet, and so there's still a lot we need to do. We were having this conversation about what this is going to encompass and how we diagnose it, and she works with a physician, orthopedic surgeon, John Brahman, who was in part of some of the articles that she wrote, and kind of his diagnostic terminology of impingement and her diagnostic terminology of impingement, and how they just don't match up, and how we need to do a better job, even for our own profession. And who knows, maybe the orthopedist will come along with us as we start to see that surgery for a lot of these patients is unwarranted and can do much better with conservative care. In regards to the Ron article on injection versus manual physical therapy, the big take home here, I think, is for those of you who have primary care physicians who refer immediately for injection, man, we got to get off of that, right? Like it's much better if they come to physical therapy overall, from a cost-effective standpoint, from an overall health standpoint, from a utilization standpoint. And why is that? Well, I think that we could argue that there's probably a lot to that. The actual guiding of somebody through the process, being there, knowing that they have something to do to help. To give them control of the situation. So we could argue that there's probably a lot of reasons why they maybe did a little bit better. But I think the big deal is to make people aware that for far too many clinics, injection is the first choice. And if they don't get better with injection, maybe we'll send you to physical therapy. But this is easy, but it's expensive. And ultimately you end up spending more money. So be wary of that if you're in an environment in which that is the common path. The Guerrero article on shoulder instability, I think the big thing is to understand what we're assessing and how we're treating it from an assessment standpoint, looking for laxity, sulcus signs, and then the lack of, just the general hypermobility and what that really represents, and then how you treat it gives some really good examples of how to treat it. Just strengthen. You just can't get them strong enough. Strengthen scapular stabilizer, strengthen rotator cuff. And overall strengthening, moving from open chain to more closed kinetic chain. I love closed kinetic chain stuff for these people. Well, for pretty much anybody, I'm a big fan. Okay, adhesive capsulitis. I'd just like to say, there's a couple of things that I think are really important when you think about adhesive capsulitis from a characteristic standpoint. These people who typically walk into your office, they are typically diabetics. This is a common generalized presentation. They're diabetic. They tend to be female. They tend to be over the age of 40, somewhere between 40 and 60. They don't have a true capsular pattern. I shared with you some article about how that the capsular pattern really, probably for those of you who were taught it in school, really doesn't seem to hold up. They have stiffness and they lack internal and external rotation. They're highly irritable and they're lacking motion. Sometimes people will figure out, well, is this adhesive capsulitis or is this a rotator cuff tear? Obviously, the quick and easy way to just find out how strong they are in their cuff with manual muscle testing. If they're strong, it's not a cuff tear, right? This is an adhesive capsulitis. Irritability and staging is really important because that's how you know how aggressive you can be. I shared with some of you an article about grade immobilizations, grade 3, 4 versus grades 1, 2. I typically used to be more aggressive, thinking I needed to really mobilize that capsule. Turns out you don't need to. You just need to get some motion into that joint. Cortisone injections, I think, can be beneficial for an irritable shoulder. I typically give the patient 2 to 3 visits in my clinic. If they can't do the exercises at home, if they're unable to get it to calm down, we go have that cortisone injection, intra-articular cortisone injection, and then they come back and they can proceed. And then tendinopathy, I didn't speak to a lot of people. As a matter of fact, I don't think we talked about the Krupp article at all with anybody in regards to biceps tendinopathy. And the only thing I would say to that is tendon pain, tendinopathies should be treated all pretty much the same. They need to be loaded. They need to develop load tolerance. Isometrics for 45 seconds a couple of times is a great way to decrease pain, and then you need to slowly and progressively load them. I say exercise is progressive, and it is progressive and consistent. Activity is random and inconsistent. We need to exercise so that you can tolerate activity, whether it's a patellar tendon pain or it's bicipital tendon pain or it's lateral epicondyle tendon pain, ECRB pain. Doesn't matter. Maybe we'll talk about that further with elbow-related things, and we'll talk more about tendon-related pain. Okay, moving on to block 3. So we're going to talk about regional interdependence, which I think is going to be really good. We've already kind of started to. Some people have sprinkled that into some of their conversations. I've certainly seen. So we're gonna blow it up and do even more. It's going to be good stuff. I really like this block. New groups Sunday night. So we're going to start new groups. I've got the groups are attached. So please check them out. I just want to mix them up so you guys have exposure to different people, different ideas, different thoughts, different backgrounds. I'm going to hopefully have your grades up by Wednesday night so that you'll have both block 1 and block 2 grades along with your group project. And if you have any questions about that, please feel free. I gave you some feedback after that first week. Hopefully some of you really took it to heart and brought in more research. And not only, what I'm looking for is, not only am I looking for you bringing in more research to support your thoughts, but also trying to meld the clinical aspects of your care with the research, how you're going to continue to do what you do because the research supports it, or how you're going to change, maybe not all, but some, because you've read something, you're like, oh, that's interesting. I have not been doing it that way. So that's what I'm really looking for. The objective group project 410, it begins due to the following week for discussion. So I'm not going to send it out this week. I'm going to send it out next week. If you want to go to the group area, and you certainly, I think it's already in the Dropbox folder. You can, I guess, if you want to get started, and if you don't know where that is, please ask me. Otherwise, I'm going to send it out next week. And then for those of you who are looking, the fit evals are posted in the block, and you can go ahead and look at those and see what the video, see how a fellow in training is doing their eval and what that looks like, and then the comments and feedback that we give back both for Scott and for Marco. So hopefully, so that's it for block 3. Hopefully you guys are all doing well and ready to dig in. Did well with block 2, ready to dig in for block 3. I saw that we did slip a little bit as far as conversation goes. So just remember, you get the most out of this class if you really dig into the conversation. So don't forget to do that. Don't wait until Friday night. It has a tendency not to yield great conversation. Otherwise, have a great weekend, and we'll talk to you all soon. Bye-bye.